Okay, I think we can get started now. So, hi everyone. Glad you could join us for our February meeting. We're actually doing a joint journal club with our friends at Global Orthopaedics at Johns Hopkins tonight. To start off with introductions, I'm Ian, one of the program coordinators for the Johns Hopkins Center for Global Surgery, formerly the Johns Hopkins Global Surgery Initiative. We recently got approval to become a center, so that's exciting. So I'd like to welcome our guest speaker for this evening, Dr. Ryan Guilbault. Ryan is a fifth-year orthopedic surgery resident at Hopkins. He is originally from Ottawa, Canada, but pursued his undergraduate studies at the University of Georgia and attended medical school at Mercer University. Tonight, we have the pleasure of listening to Ryan share about the global surgery projects he has been engaged in, as well as offering insights from his background and perspective in orthopedics. Recently, Ryan has traveled to Zambia, where he is currently developing a limb deformity curriculum and a patient database for research. So we'll get to hear more about that. To go over our session tonight, Ryan will start by providing an overview of his career and sharing his personal experiences in global surgery. Following that, Ryan will speak on the two selected articles for tonight, and there will be opportunities for questions and comments throughout the session. Now I'll pass the floor over to Ryan to share more about himself.
Thanks, Ian. Appreciate it. I'm actually going to switch up the order if that's okay with you, because I picked the articles because I think they set up some of the things I'm going to talk about later on during the my PowerPoint a little bit nicely. So it gives some background for some of the topics that I bring up later. As Ian mentioned, I have a strong interest in global orthopedics, global surgery in general. And so I've been on a handful of trips since starting residency, but really my journey in this field started well before medical school. I've been going on mission trips, either faith-based trips or non-medical trips since I was about 12 years old. And I've been getting, all sorts of feedback from different people throughout the process that have kind of guided my point or my mission up to this point. And after this summer, I'm going to do a fellowship in pediatric orthopedics in Boston, and then do a limb deformity fellowship in Australia for a year. And then I'm speaking with a few different organizations in Africa and Southeast Asia to most likely do a full-time commitment in one of those locations for at least a few years following a fellowship. So that's kind of my leaning and my 5-year plan. I'll keep you guys updated if things change, because as you know, this whole field is very dynamic and things tend to change and fluctuate relatively frequently. So don't hold me to anything I say, because everything shifts on a dime. I'm going to start with the first article, the Global North and South Partnerships. And I'm just sharing my screen just so people who didn't have a chance to actually read the article can at least see the abstract. But basically, this is a non-orthopedic specific paper, and it's a relatively old article. I think it's from almost 15 years ago, but it focuses on some interesting topics that I think are kind of overlooked when it comes to medical mission trips or medical projects in particular. And it focuses on improving sustainability in the global North and South partnerships. So the global North is not necessarily a geographic term for people who aren't familiar. It's just basically the people from the host or the student or surgeon or whoever is traveling to the other place. So the global North in our case would be Baltimore, Johns Hopkins, and the global South would be whatever location you're traveling to, whether that's physically north or south of here is irrelevant. But the purpose of this article is basically reviewing a body of research and a specific student's experience in Nairobi. And it wasn't actually a medical mission that he was going on, but he was working on microfinancing in a Kenyan NGO. And the purpose of the article was basically to highlight that mutually beneficial relationships are what are most important and impactful for global North and South partnerships. And if you can be somewhat flexible during the process of both setting up your trip as well as your goals, you probably will end up gaining a lot more from the opportunity. And both the North and South partners will end up having a more impactful and long-term relationship with one another. So the three main highlights that the article goes into, it talks about first and foremost, maintaining flexibility. So the example they gave was a student from McMaster going to Nairobi, working with a small NGO. And the student went to Nairobi with no designated goals prior to the trip, but they had regular meetings and check-ins with both the global North and South hosts, and then they evaluated the student's progress throughout this point. A second point was that they should focus on participatory observation, which is basically the idea that the student is active within the NGO, but takes kind of a backseat role, and that they're just kind of observing how the NGO works, and from that observation can then decide how they could be most helpful based on their skill set as well as the NGO's goals. And this helps align goals with both the host organization and establishes a sense of belonging in a new community. And it makes it more likely for the individual to develop a mutually beneficial project with the host organization that's sustainable. And then the third point that they brought up was that sustainable change takes time to develop. And so often trips, at least that medical students or residents are going on, are somewhat short term because they have obligations back in their home. And so it's important to be patient and understand that your involvement in an organization as a volunteer may be bigger than yourself, and you may be helping to perpetuate or establish a relationship between organizations, and you are just a face of that organization. So taking that into account and kind of putting yourself in the shoes of both the global North and South's organization, and kind of thinking outside of yourself during the time that you're there. And the only other comment that I had on this paper was that they brought up an interesting idea. It's called reverse innovation, and I don't think it's that new anymore, but at the time of this paper, it was somewhat innovative. And it's the idea of bringing ideas or systems from the global South back to the global North. And so up to this point, many of the benefits or the topics that the global North volunteers would talk about would be either educating or bringing resources or infrastructure to the global South. But the idea of then maybe bringing some similar ideas back from the global South to the global North would help, again, establish this bi-directional relationship with both organizations and make it more meaningful in the long term. I don't know if anyone had any ideas about this particular paper, but I thought it's interesting. Again, it's maybe not as relevant for medical missions or projects, since they may have to be slightly more rigid. One, based on time, and two, based on the fact that you're taking care of patients, and so tend to need to be a little more goal oriented. But sometimes when you're setting up infrastructure or helping improve systems in global South type projects or hospitals or clinics, then it can be helpful to kind of keep these general ideas in mind, just so that you can have a more lasting relationship with an organization. Awesome.
Does
Okay.
anyone have any thoughts, comments, or questions for Ryan regarding this article? I guess just the comment, but in these, I guess in these volunteer programs, volunteers are often traveling to these LMICs without real understanding of the cultural contexts. So I agree for these mission trips and volunteer programs that more extensive pre-departure training to develop global health competencies is necessary. I think we're sort of missing this piece, especially when it's essential in promoting respectful and effective interactions. I guess just a question for you, Ryan, is when getting ready for your own trips, how did you prepare yourself for this and navigating the differences in cultural contexts?
Yeah, I think that depends on where you're going and how long you're going to be there. But generally, I try to establish contact with the host organization as early as possible. And um, many of the projects or the trips that I've been on have involved some sort of educational component. So, um, for example, my most recent trip to Zambia, I had established contact with this hospital over a year before I had gone there. And so I had set up weekly Zoom meetings with the residents that I was going to be working with. Um, so at that point, by over a year of weekly meetings, 40 plus times speaking with these residents, I had a general idea of kind of the level of interaction that I could expect when I got there, which is helpful. But um, it doesn't have to be that frequent or even that long lasting. Even if you can just have a couple phone calls with some people that are working there, and it's especially helpful if they're expats because they have a better understanding of both the culture that you're coming from as well as the culture that you're going to be immersed in. They can help kind of bridge that gap for you. And the other thing that I find um, is really helpful is I've identified one book about the host country that I'm going to for all these trips. And it's not always about cultural or political or historical relevance. Sometimes it's like a historical nonfiction book or fiction book, but it kind of helps me one, get an idea of what the culture might be like, but two, also get an idea for what like a daily life might be like in that sort of area, which is kind of a fun thing to do, if nothing else, on the plane ride over there.
Joseph, you have a question, you can ask it.
Thank you so much. And thank you for the article. I'm Dr. Joseph. I'm anesthesiologist, and I'm from Rwanda. And I have been involved in a global surgery for a while. What I think also we have to consider on top of the preparation, I think also we shall understand that when we go to South or LMICs, we shall consider like mutual beneficial program where uh, uh, someone coming from a developed country is coming, of course, to help in some items, but also running from LMICs, because also when you arrive, you'll find a way of practicing, which I will not say it is broken to be fixed, but also it is a system which is working, maybe which can learn from other systems. That is what I can say from my personal experience. Thank you so much.
Thanks for those thoughts, Joseph. Does anyone else have any thoughts to share with Brian, or we can move on to the next paper? Okay, I think we can move on to the next paper, Brian.
Okay, let me pull it up here. Yeah, so the next article had a more orthopedic spin. It was looking at specifically how medical students, residents, or host surgeons could get involved in the global south and considerations when they were going, depending on what type of trip they were going on. So I really like this article because it gives a very broad overview of what global orthopedics can look like. Unfortunately, it doesn't, I guess it does have an abstract, but it isn't that informative. But I'll just leave it here in case people want to look it up based on the title later on. So the article was published just a couple of years ago out of UCSF, who's been a real workhorse in terms of global orthopedics. There are a couple of different institutions in the US that have really kind of led the charge in terms of global orthopedics. And I would argue UCSF is one of, if not the most involved universities. So they've kind of established this consortium and pretty impressive infrastructure in terms of different expats living in the Global South, as well as Global South hosts who are interested in working with American-based universities and orthopedic residencies, which can be really helpful for trainees who are at programs who either don't have an established North-South partnership with the same hospital that residents can kind of select when they're going to that residency, or for residents who want to do additional work outside of what's being done at their particular institution. I also want to give a shout out to Dr. Ishmael, who's on this, one of the authors on this paper, who's one of the traumatologists at Hopkins. So the first section of the paper talks about kind of a background of the burdens associated with trauma and common problems faced in the Global South as it relates to orthopedics, highlighting the fact that 11% of the disability adjusted life years lost are due to orthopedic associated injuries, and then talks about potential barriers to care and challenges and potential solutions, as well as some ethical principles to consider during trips. And then it talks about kind of the 5 domains or 5 different spheres of global orthopedic involvement. The first is clinical care, which is kind of the backbone, or what most people think about when they think about international orthopedics or outreach. And they highlight many different organizations and universities that provide opportunities, but that these different opportunities and organizations can be disjointed and have historically not focused on capacity building. And it's important to prioritize patient safety during these trips and to consider the needs of local surgeons. And a recurring theme in both this paper and other papers is that often infrastructure and funding are barriers to local surgeons, not necessarily knowledge or education, which can be surprising or maybe not expected for some international volunteers. The next section goes on to thinking about clinical research, and it points out that only 11% of the world's scientists are from low and middle income countries. And it just highlights some tips when thinking about establishing research projects in the Global South as it pertains to orthopedics. And really, they're kind of broadly sweeping suggestions, like that you should discuss authorship and make sure that you're sharing it equally between both partners, and that you should share raw data sets equally, because it can kind of blossom into different projects depending on what the global North and South partners' interests and focus are for each project. And that research is an excellent way to establish sustainable relationships, because research projects, especially clinical projects, can take a long time to both develop and then write up. The next section is on education. And again, it aims to eliminate need for future trips by building knowledge base. And they highlight focusing on balanced and comprehensive programs and avoiding overly technical education, which may not be relevant based on the needs or the resources available in the Global South setting. And then the next section is on disaster response, which I'll touch on a little bit in my PowerPoint, but basically it highlights the fact that working in low and middle income settings can prepare a surgeon for working in a disaster response situation where there's resource limitations, but a disaster response situation is typically challenging and that there's an overwhelming volume of patients in addition to limited resources. And so it requires a totally different set of knowledge and expertise, training. And so it's often used as an example to highlight ethical considerations and dilemmas, particularly when considering volunteerism, and that surgeons in particular can travel to a situation where they don't necessarily know what they're getting into, or are not necessarily wanted or needed in a setting, which again I'll highlight in a couple of slides during my presentation. And then last, it talks about advocacy, and it just highlights the fact that there's a growing impact for virtual education and research capacities and global opportunities after and during COVID, and that this is kind of setting us up for the next kind of few decades of international work. And that there's continued need to advance care in the field. I think this is a really great paper, but more importantly, if anyone gets anything out of this, I think everyone should take a look at this appendix. It has an amazing supplement looking at all the different organizations that you can get involved in when it relates to global orthopedics, as well as different contacts in different areas, depending on what your interests are within ortho. I don't know if Dr. Oni or Dr. Hegde have any comments or suggestions, since they both know a couple of people on this paper.
Yeah, I do think nice review, Ryan. I really appreciate that. I do think this paper goes into significant details with highlighting some pertinent issues that people going into this places deal with. Obviously, there's no paper that could do justice to this topic, really, and but I've chosen not to critique it significantly. But I think for the most part, they try to address a lot of those issues. Yeah, I think for the most part, papers like this are how we're going to be able to like go into this into lower middle income countries and participate, collaborate, and contribute in a way that is respectful to the local culture and to and helps to system build and capacity. Like capacity build and build sustainable systems. So that's what I'm hoping that we can all strive for, instead of this one and done type of trips that we have for the most part done. And I think papers like this are going to be ones to kind of guide the template in for it. So thanks for choosing this paper for sure. Thank you.
Thanks, Dr. Oni, for your thoughts on the piece. And thank you again, Ryan, for a great overview of the article. Yeah, it's a really nice article you picked out for us. Does anyone else have any thoughts, comments, or questions? I guess I have a question. Often HICs are seen as the ones bringing knowledge and teaching LMICs. So I'm interested in hearing about any lessons or insights you've gained from working with your counterparts in LMICs.
Yeah, I don't know. I have tried to focus on education infrastructure, and bringing something to each of these trips to share with the host. But I feel like often, if not every time, I end up walking away feeling like I've learned much more than I've taught. And all of the teaching that has come my way has been really variable, just depending on the setting and the host and the location. I think the most substantive and probably reproducible example is using sign nails, which for the non-orthopedic people in the audience are basically intramedullary nails used to fix long bone fractures, but they can be used without X-ray or fluoroscopic guidance, which is not typically, if ever, used in the high-income countries or global north, just because all the hospitals have access to implants that use X-ray, and every hospital here has X-ray capabilities. But for the global south, they may have frequent power outages, or they don't have the resources available to have X-rays in the OR. So, I mean, that's just a very easily and probably frequently cited orthopedic example, just because those aren't surgeries that we typically do in the States. And you know, there's countless other examples in and outside the OR of things that I've been taught on each of these trips.
Yeah, that's awesome. I'm sure you have a handful of experiences. Thank you for sharing that with us, Ryan. I guess we can move on to the presentation you prepared for us tonight.
Sure. So again, just to preface all of this, I'm certainly not an expert in anything when it comes to global orthopedics. I have a strong interest, but there are many people even within this audience that have more experience than I do. So if anyone has any comments as I'm presenting here, please feel free to pipe in and add your own spin and help all of us understand a little bit more about where you're coming from and how we can improve. Because ultimately that's what all of this is about bringing care to everyone in the world in an as equitable way as possible. So briefly, I'm going to talk about different types of orthopedic trips as was highlighted in that last paper, and then talk a little bit about both teaching and research opportunities, and give a few examples from the most recent trips that I've been on. And then I'm going to talk briefly about how to get involved in orthopedic outreach, and something that I was never formally taught. So I've kind of been taking notes during each of these trips on like some organizational steps that people can do leading up to trips that I think would be helpful. And then I have a little resources slide at the end if people have questions or websites that want to look at more info. So again, there are many different types of trips, and I'm going to touch on all the ones that we previously talked about, including faith-based and domestic assignments. These are kind of areas that are typically not highlighted during these types of forums, but I think are also important. And it's not necessarily global orthopedics, but domestic assignments can also be a really helpful way to at least get your feet wet before you go and do a trip internationally, because a lot of the topics can be the same without any of the culture shock. There's a picture from Liberia with a couple expats, all US trained surgeons that are living there and working. And I think the one on the left maybe ran out of scrubs, so they only found the smallest and pinkest scrubs they could to give him. So the first type of trips that I want to talk about are disaster and relief trips. These can be pretty intense. Typically involve some sort of humanitarian efforts involved with either some sort of natural disaster or political calamity that involves a high influx of orthopedic injuries that overwhelm a local system. And so there are many different organizations that you can get involved with that are listed on the left here. The common theme for most of these trips are that they are relatively short assignments because they are so intense, and they tend to be in somewhat more dangerous or remote areas. This image on the right here is a trip that I went on to Liberia, and that was a mobile surgical unit that we were taking into Sierra Leone in a kind of a civil war setting that we were going to a relief clinic. Sign, as I mentioned in particular, is a organization that can involve surgeons from around the world. It's actually a network that was developed by Dr. Zirkle, who's an orthopedic surgeon, and his company is now based in Washington. But again, it's used to nail or stabilize long bone fractures without fluoroscopy or X-rays. And using sign nails involves big incisions, open reductions. They have general education modules that surgeons can access from around the world online. He donates the nails free of charge to both the surgeon as well as the patients, with the understanding that they upload pre and post-operative information into a database that they continue to do research, which obviously benefits the patients, but also the surgeons using the tools so that they have some sort of quality check or outcomes check, which is, you can see on the right here, that's one of the surgeons I was working with in Liberia who was teaching me how to use sign nails, because I'd not use them very frequently, if ever, in the US. I mentioned some of the considerations for political instability, for disaster relief trips. Of particular note is that aid workers are typically targeted by terrorist organizations or militia, so it's important to take that into consideration. And again, these tend to be shorter trips because they tend to be more intense, and often use something called damage control orthopedics as opposed to definitive care, where you're providing temporary relief for a patient until the system that they're in is no longer overloaded, so that they can get more definitive care in the future. Next are surgical or service-based trips. These are typically what you think about when you're thinking about global trips. And there's a list of orthopedic organizations on the left there that offer pre-organized trips for these purposes. Again, these are self-contained and they focus on clinical care delivery. My most recent trip to Zambia, which you see on the right there, was at a Cure Hospital, which is a faith-based network that provides orthopedic, ENT, and plastics surgical care to pediatric patients specifically. So they have a network of hospitals across Africa and the Philippines, and they also pair with local surgeons and local residencies, which is the residency that I've been paired with for a few different education and research projects that I'll talk about in a little bit. I think it's also important to talk about domestic assignments. There are lots of local clinics, and there's certainly lots of local need in Baltimore. Operation Walk and Touching Hands are both international organizations, meaning that they're US based, but they have trips that surgeons travel across the world to do surgery, but they also have domestic outreach projects. And so if you're interested in potentially getting involved in global orthopedics in the long term, but want to kind of see how you can have a more lasting or sustainable impact, these are good organizations to maybe try partnering with while you're still in the US, and then maybe trying international or global project later on. And then the IHS is also an interesting domestic volunteer opportunity. I've been to one trip to Navajo Reservation for a month in Utah, like the Four Corners area, and it was a really eye-opening experience to see all the need that's still in the US, and all the good that you can do, and the lasting and sometimes much easier to get to places so that you can have a more lasting impact if you don't want to leave your family or prefer to stay in the States as compared to travel abroad. Next are education-based projects, and I'll touch on these in more detail in a little bit, but there are lots of organizations that now focus on education-based outreach, just because there's been a real swing away from clinical or surgical-based trips to education for the reasons that we already discussed. You can see Cure International is here, but HVO, or Health Volunteers Overseas, has also really stepped up in this department and really pushed surgeons to establish education-based projects either domestically via virtual education, or to travel abroad for short and long-term trips to help establish education systems for surgeons and trainees abroad. And you can see on the right here, this is a trip to Haiti that I was working with some local residents on a limb deformity curriculum, which was a need that they had stated was both important to them and relevant based on the patient population that they were seeing. And then I just want to highlight the fact that for these education-based trips, there's lots of opportunities to travel abroad and to teach, but COVID was terrible in a lot of ways, but a good thing about, or a silver lining of the pandemic, is that it really kind of forced people to become more technologically savvy and communicate with virtual technology. And so the capacity for many hospitals, even in the global South, has really expanded over the last decade. And so I've quote gone on many outreach trips to Western Africa and the sub-Saharan Africa for deformity-based trips by just joining a WhatsApp group that is literally just housing 5 or 6 US-based surgeons who have some deformity experience, and they just look through x-rays that people around the world have gotten this WhatsApp group number from, and started out with maybe one text a week or so and kind of a long or lengthy discussion about each case and the different options, and now involves maybe 20 or 30 cases that come in every day, and then different surgeons are kind of blocking them off and pulling the surgeons aside independently to go over different options. So if you have a particular interest, I'm sure there's a similar WhatsApp group or informal education opportunity for pretty much anything you're interested in. But even things like email or Zoom are a great opportunity to get involved. And obviously teaching doesn't necessarily mean you have to physically be present somewhere. So things like augmented reality and virtual reality are becoming more of an option for even some middle income countries where there's larger groups of trainees who want expanded education opportunities. And so augmented reality headsets can be donated, and as long as there's a stable internet connection, it's a more sustainable education opportunity where they can communicate with the Global North partner. There's a group in Brown University that's developing an education curriculum in Uganda, I believe, based on an augmented reality education model. So I just wanted to briefly talk about the Haiti experience. There were a series of earthquakes that kind of decimated Port-au-Prince, which is the capital in Haiti, and it killed hundreds of thousands of people. And there was a huge outpouring by the Red Cross and a couple international organizations to attempt to help the people of Haiti, since the infrastructure there was already not set up or equipped to handle even the baseline demands of the population, much less the demands of a natural disaster of that scale. And so there was a journal in orthopedics that's very popular called Core, Clinical and Orthopedic Related Research, that assessed the response to the Haiti earthquake in 2012, and basically sampled both the Global South and North partners involved with the project about how they thought things went. And it was very telling in terms of both the misconceptions on both sides, as well as ways to improve the process. And so, they published a little bit of data, and they showed kind of the response curve and how many respondents or surgeons showed up based on the time after the earthquake. But then they were more importantly looking at outcomes and tracked some of the procedures that were done, and showed a pretty astounding revision rate. And this was excluding things that you would expect revisions for, based on the population that and the injuries that were present. So in response to this experience, the AOS and some other organizations that are kind of governing bodies within orthopedics came up with this framework and criteria for orthopedic surgeons responding to natural disasters as well as political disasters. And they have some now required training modules for responders that are going to these areas, and a lot of guiding principles that are hopefully improving some of the outcomes in these situations. I know there's a few different research studies going on involving the Ukraine response, as well as the recent earthquakes in the Middle East, so as well as Nepal. So hopefully we're using this data and some past mistakes to improve future responses, but I'm sure there's still a lot to be learned. So keep an eye out for some of those papers coming out in the future. So I want to talk about a little bit about teaching opportunities. My experience has mostly been with residents, but because that's my level of training, and so that's going to be kind of my focus. But I know Laheen, who's been on a few long-term trips, or at least one long-term trip, can give a different spin in terms of the medical student experience. And Dr. One and Dr. Hegde, if they're still on at the end of the talk, could probably offer some different insights in terms of a surgeon, attending surgeon experience. But the overall, or the overarching theme for all of these experiences and trips are basically to first and foremost partner with your global South host and decide based on their response and feedback what they think is appropriate in terms of their needs and their patient population, and take that as a first step to help guide whatever trip you're going on. On the right was a trip that I think I've highlighted a couple of times now to Liberia, and there were a few residents that came through the hospital that I was working at, but most of the needs that the host identified when I started speaking with him were infrastructure needs. So you can see the hospital that I was working at didn't have an AC unit, didn't have reliable electricity or lights, and no x-ray. So I spent the better part of a week being a handyman instead of a surgeon. So you can see the AC unit that I installed up on the left, and then we fix a solar powered generator on the roof of the hospital, and then this is us installing some OR lights. So I love teaching and I love education, but sometimes my expertise as a YouTube handyman comes in more handy than maybe any of the orthopedic knowledge that I have, because it's relatively limited as compared to even some of the other surgeons that I've encountered in these situations. HVO is an organization I already highlighted, but they have really amazing capacity and a desire to build education projects, and they're not specific for orthopedics. So I kind of listed some of their projects that they're working on, including things like nursing education and hospital administration, even, as well as general surgery and pretty much every subspecialty within medicine. And they have plenty of virtual opportunities as well. I think it's important to kind of center ourselves from going on trips like this and remember how lucky we are. Don't make assumptions about the area that you're going to. And again, I'm going to say this over and over again, but make sure that you talk with your host organization and figure out exactly what they need and what level of teaching is appropriate before you go. Teaching basics has been something that I've focused on a lot, especially with residents, teaching surgical approaches, soft tissue handling, infection management, where I often learn more from the residents that I'm quote teaching than I'm teaching them, since there are many more infection cases and many of the locations that I've been to than we see in Baltimore. But also going back to the basics, this is a hospital in close to Sierra Leone that I was at, and you can see their medical record keeping needed a little bit of work. So there was a local IT expert that I worked with there to try to set up an EMR system for them that we're still struggling through because there's a lot of data to input, as you might imagine, but we're making some progress. So again, trying to find ways that you can be helpful, whether it's in or outside orthopedics, and emphasizing solutions that are feasible based on the resources that the setting that you're in, as well as solutions to problems that they see. So, you know, the pathologies that we see in the States or even at Hopkins may not be relevant to the global South partner that you're working with. So make sure that, again, you talk with your global South partner and decide what's appropriate and what's relevant there. And then minimize discussion of complex problems and technical surgeries or high risk surgeries, as these may not be appropriate based on the resident or the surgeon that you're working with, or based on the follow-up care. You have to consider other informal teaching opportunities as well. So you can see on the right here, this was in Haiti, and the group of residents that we were working with, we often stopped outside each room to talk about the etiology, pathology, different surgical options, and then post-operative care for pretty much every patient. So we had a long list and lots of cases to do, but the most fun part of that whole trip was just talking with the residents and kind of picking their brains about what their thought processes were for some of the same problems that we see in the States and how it's handled differently. And then there's plenty of education opportunities for even non-medical trainees, things like nurses, physical therapists, prosthetists, pharmacists, even intake staff. On my most recent trip to Zambia, the very last week, I had a group of anesthetists came up, and they asked me if I could make a presentation on SCFEs, which are slip capital femoral epiphysis, because they had seen so many in the operating room and no one had really explained to them what was going on and what to consider for from a medical perspective. So you'd be surprised about what sort of teaching opportunities are wanted or needed in the location that you're going, and you'll never know unless you ask someone. And then I already mentioned some of the infrastructure opportunities, but there are other teaching opportunities outside the OR that can also be important for some of these trips. So things like timeouts, crash carts, basic life support training, which are easy ways and very feasible education projects that people without orthopedic specific knowledge can still make an impact, or medical students who are interested in trips like this and are interested in general surgery or pediatrics or whatever it is, can easily have an impact and create a sustainable project in a location that they're interested in helping. You can see here it's more handyman work with a group in Haiti. It really helps if you know how to use a wrench and a drill outside the OR on most of these trips. Research opportunities are also a great way to make a lasting impact, very similar to education. And the setup is, for me, is very similar. So again, talking with the host organization, figuring out what their wants and needs are, and then more importantly, figuring out what is realistic and interesting for them to study. So when I initially started working with this group in Zambia, my interest is in limb deformity, and they were very interested in learning about that because it's a common problem that they see. But in terms of research, they didn't have the capacity to or the volume to necessarily study that. But one of the surgeons was very interested in different hip pathologies for pediatric patients. And so I helped them set up a database because that's what the host surgeon really wanted to work on. And so I found that because of the host surgeon's buy-in and some of the residents' interest as well, we've gotten much more productive research group than if I had kind of tried to drive the bus in terms of what sort of research project I was interested in studying. And so again, establishing that bidirectional relationship from the beginning can make it, one, way more impactful, and two, way more productive for both institutions. And again, from a medical student perspective, you may not have the expertise or knowledge or even interests in some of these more technical research projects, but even talking through how to do a literature search or scientific paper critique, hosting a journal club are all topics and things of interest to medical trainees around the world, but not necessarily something that they have time or prior training on, and something that most North American trained surgeons and medical students have been exposed to. So I sat down and showed a group of Botswanian residents how to do a PubMed search, and I thought it was like the coolest thing ever. By the end of the week, they were all bringing in papers to show me, and we were kind of setting up an impromptu journal club. But that's also something that you can easily do virtually, which is a great way to kind of establish a relationship with a group of trainees or surgeons without actually going to a location, or helping to build up your relationship before you actually go to a location to do a clinical project. And again, the research opportunities are a great way to establish longitudinal relationships. So you can think about complications and have a more lasting impact. You can even study some of the patients that you were involved with clinically during your trip, and that can be a way that, one, you leave a lasting impact for the residents or surgeons that you work with, but also as a way to establish more continuity of care and not have this kind of drop in, drop out mentality or volunteerism idea that's been more prevalent in the past. I think it's most important that everyone who is interested in global surgery just get excited about it. And often you'll see a lot of negative papers talking about how it's not good to get involved in global outreach because other organizations or locations don't need you for you. They need more money and infrastructure. And while that may be true, I think that there's still a lot of need. And generally speaking, people are really grateful for any sort of time and effort and energy that you're willing to give them, and even just establishing contact. So I don't want any of these research papers or review articles that we talk about to discourage anyone from getting involved, because it's one of the most amazing experiences that you can ever be a part of. A few factors to consider when you're going on trips are things like your experience, your expertise, where you're going, what your level of training is. And again, communication is key. So making sure you talk to your host as much as possible beforehand to get an idea of that your level of involvement and what you can contribute when you go there. It's definitely important to think about cultural differences when you go. Here's a trip that I went to in Morocco, and there was a very conservative Muslim population there. So there was a lot of considerations that I wasn't necessarily as familiar with based on my prior trips that I had to read about and be aware of while I was there. Also important to be considerate of local politics. So there may be a different hierarchy of officials and physicians and trainees and the location that you're going to. So it's really important to be respectful, and again, be an observer and be involved, but don't insert yourself in ways that you may not appreciate are either rude or obtrusive. On the picture to the right here is me with an anesthetist in Zambia who was hired and started literally at the bottom as a clinical officer and kind of worked his way up to a physician role. And so he was somewhat looked down upon by some of the other anesthetist in the group, and he kind of explained the process of medical training in Zambia to me. It was really an eye-opening personal connection that I made while I was there. Also really important to know what resources you have and what you can expect in the area that you're going to. OR time, anesthesia limitations, antibiotics, implants, radiology, therapy, prosthetics, all these things are super important and specific for orthopedics, but regardless of what type of trip you're going on, there's a ton of different considerations that you need to take into account. Things like autoclaves, as you can see on the right, may be limited. So making sure that you do your planning and homework beforehand is really, really essential. And then I just have a couple of tips here, things that you might want to consider before going on trips and a timeline. So I won't go through all of this stuff, but just know that maybe even 6 months to a year before your trip, it's important to kind of think about some of these things and do your planning and diligence beforehand so that you can maximize your time there and minimize your negative impact and kind of augment your sustainability. Also really important to make sure that you are medically prepared for any trip you go on. So there's a lot of great websites and resources at the CDC. The picture on the right is me getting quinine infusion for malaria when I was on a trip to North Africa. Unfortunately, the malaria prophylaxis that I got was incorrect for the type of malaria that I was exposed to. So do your homework and don't make the mistake that I did. And then a couple of months before the trip, again, keep doing your homework, keep in contact with your Global South partners so that you can avoid some pitfalls that other people have fallen into before. And make sure to be respectful, make sure to dress professionally, and again, talk to your host to see what is appropriate and what isn't. There's a lot of things that you may not think about when you're going on a trip, and the Global South partner may be so accustomed to that they may not think about telling you. So I've kind of made a list of things that is important to me. I'm not necessarily picky when it comes to food, but there's only so much capencha that I can eat, which are these kind of tiny bony fish that was offered at lunch every day for a month when I was in Liberia. So just be aware that you may need to pack and prepare for the unexpected. And then always be prepared for your work travel too, which again just comes down to communicating with your Global South host. And above all, remember that you're a guest, that you were invited somewhere, and so that you should treat your host and the patients that you interact with the same compassion and respect that you would if you were back in the States. So key takeaways, again, there are many different types of trips that you can get involved with. Education and research are ways that I've used to make a more lasting and sustainable impacts and develop relationships on the trips that I've been on. And always make sure to talk with your host before you go to maximize that relationship and your sustainability. If you want to connect with me, those are my email, my cell number. I'm happy to obviously talk about this for hours at a time, but if you have specific questions, I'm happy to answer those for you. And thanks so much for your time and your attention.
Thanks a lot for your presentation, Ryan. It really gives us a glimpse into your experiences and the world of global orthopedics and a lot of the different avenues for engagement. I also really loved your slides on your recommendations on what to do a few months before the trip. It seems like a perfect checklist for someone who's wanting to get into global surgery. So it looks like we're just a few minutes over. So those in the audience, feel free to share any last minute thoughts, comments, or questions you have for Ryan. Herman?
Thanks, Ryan, for your presentation. I just want to ask you from your experience and whether you think putting into consideration the disease epidemiology in LMICs is something that somebody should consider. For instance, we have prevalence of infections like osteomyelitis, or variation with deformity. Should this be something one needs to consider before moving?
Sorry, I was having trouble hearing all of your question. I don't know if anyone else had a better connection. You could maybe re-summarize that for me. Or maybe if you want to type it out in the chat.
While we wait for Herman, maybe if there are any other last questions for Ryan. So Herman is asking, would you advise putting into consideration the variation in disease epidemiology before a visit to LMICs?
Yeah, definitely. There's certainly different pathologies and complexity of pathologies that you're going to see depending on the location that you go to. I think if you're talking about clinically, it's probably best to talk to the surgeons or trainees that you're going to be working with to get an idea for what types of problems they're encountering. If you're talking about from like a research or education perspective, again, talking with both your global north and south partner in terms of what the resources they have as well as their interests in certain topics, I think is probably most pertinent. But yes, to answer your question, there's definitely much different orthopedic problems that I've seen in these global south partners that I've worked with as compared to what we see here in Baltimore.
Great, thanks. Any other last questions? Great. So I'd like to wrap up this Journal Club session by thanking Ryan for being our guest speaker and delivering such an informative talk. I'm sure I can speak for everyone that we've really gained valuable insights from your talk tonight. And also thank you everyone for attending tonight's session. And we look forward to seeing you all again next month. So have a good night, everyone.